first part of the fetus that we can actually see is the fetal heartbeat. This is visible starting at 6 weeks gestation, and that's really the only part of the fetus that we can identify at that gestational age. But by 8 to 10 weeks, we begin to see some of the fetal structures, including the rhombencephalon and the limbs. And from 10 to 14 weeks, we can see quite a bit of the early structural anatomy of the fetus, as well as the nuchal translucency. So at an 8 to 10 week ultrasound, we may see the development of the brain, the rhombencephalon being the most prominent part at this gestational age, which appears as a cystic structure in the posterior aspect of the cranium. The brain develops as a fluid-filled sac as it folds anteriorly, and you can see that it's mostly fluid-filled with an expansion of fluid posteriorly as well as anteriorly. And then it begins to divide until we have the two halves of the cerebral hemispheres. So at 8 weeks gestation, this is a sagittal view through the fetus. We can see that rhombencephalon here, the posterior aspect of the brain, as well as the fluid-filled structure of the anterior aspect of the brain. And this is just a 3D reconstruction of the fluid-filled aspects of the developing brain with the rhombencephalon and then the cerebral hemispheres. Also between 8 and 10 weeks gestation, we begin to see the limb buds. Here you can see on grayscale imaging of two different fetuses at 9 weeks, we see little bumps coming off the trunk of the fetus here as well as here. Notice that the size of the fetal head is about half the size of the entire fetus at this gestational age. And with our really high resolution ultrasound scanners now, you can see with a 3D ultrasound, you really can see the limbs quite well on this fetus, the upper and lower extremities on each of these. This is a 9-week fetus. But it turns out now from 10 to 14 weeks gestation, we can begin to actually see some of the structures in the fetus and identify some very important anomalies of these fetuses. We can look at the cranium, the brain, even the face. We can look at the nuchal translucency. We can look at the trunk and the thorax, as well as extremities. Studies have been done recently showing that the detection of major anomalies from 10 to 14 weeks can reach up to about 50%, particularly if transvaginal scanning is performed. This type of scanning is particularly useful in obese women. At 10 to 14 weeks, you still can see the entire fetus with the transvaginal scan, and if they come at 16 to 18 weeks, because of their obesity, you may be able to see none of the fetus. So some are advocating a 10 to 14 week scan in obese women using the transvaginal scan to at least help us detect some of the major anomalies. The highest detection rate falls among fetuses, as you see here. We detect about 53% of central nervous system anomalies and 100% of anencephalics and holoprosencephaly. It's possible to pick up about half of the cardiac anomalies, but particularly the severe ones like hypoplastic left heart and the AV canals. Some of the other anomalies, gastrointestinal, we can pick those up, but our lowest detection rate is for the genitourinary anomalies, often because these develop during gestation. So we'll start by talking about the central nervous system. The kinds of things we might see are anencephaly, encephaloceles that are large, holoprosencephaly, even sometimes some neural tube defects, and facial clefts. This is a 9-week fetus on a transvaginal scan. You can see it looks a lot different than the 9-week fetus I showed you that had those nice extremities. Instead of a nice rounded cranium at the top, we see a very irregularly shaped cranium. This is the dystrophic brain tissue that develops and protrudes out from where the skull should be in fetuses who have anencephaly. This fetus came back at 18 weeks gestation. Here we can see the typical appearance of anencephaly with the eyes and lower face formed, but no cranium, no forehead here. On sagittal view, no cranium above the spine or behind the face. And this is the 3D reconstruction showing the lower face, the ear, and then absence of the cranium. At 11 weeks gestation, you still will see that dystrophic brain tissue, and the dystrophic brain tissue that you see in these fetuses with anencephaly spreads out around the face and behind the face. So the way to pick this up is the abnormal contour to what should be the cranium, because at this stage often the cranial bones are not well enough formed to see the actual ossification, but you can see this lobular, regular contour of the cranium, and this is an important indication of either a huge encephalocele or anencephaly. This fetus has an encephalocele. In attempting to measure the nuchal translucency in this fetus, we saw elevation and protrusion through a defect in the skull with a solid mass protruding out. That's the extruded material in the encephalocele sac. And this fetus has Holoprosencephaly. We had a clue to the abnormalities that would be found in this fetus because of the large cystic hygroma behind the neck. And our view of the head shows a single ventricle crossing the midline here, absence of the falx, fusion of the midbrain, typical appearance of Holoprosencephaly. Now the nuchal translucency is that hypoechoic band behind the fetal neck. It has, at least for the time being, come to play an important role in the screening of fetuses for chromosomal abnormalities and cardiac defects. It's been shown that thickening of the nuchal translucency is associated with an elevated risk of aneuploidy and anomalies. And the thicker the nuchal translucency, the higher the risk. So here are two pictures from a fetus with measurements of the nuchal translucency. You can see it's that hypoechoic band behind the neck, and we've measured it from the inner edge of the hypoechoic band to the inner edge to get a thickness, in this case of normal, 1.3 millimeters. It is important to measure these things adequately. Technically, the fetus should be in a mid-sagittal view. The image of the fetus should be enlarged because by enlarging the ultrasound acquisition plane, you are improving the resolution with most systems. The fetus should be in neutral position, not hyperextended or hyperflexed. Be sure to measure the nuchal translucency and not the distance between the fetus and the amnion, and measure it at its maximum width from inner to inner inside the hypoechoic band. So here we have a blown up view of the fetus. The fetus should occupy approximately half of the image, with only part of the fetus visible. We want a mid-sagittal view, and one of the ways to confirm that is to see the nasal bone. We don't want the fetus hyperflexed with no fluid under the chin, or hyperextended with greater than 90-degree angle between the chest and the chin. We want to separate the amnion from the posterior aspect of the nuchal translucency and only measure this hypoechoic band from the inner edge to the inner edge. This one was normal at 1.1 millimeters. So here's a fetus in a nice sagittal position. We don't know if this is in fact the nuchal translucency or just the amnion behind the fetus, so we'll watch and wait. And then when the fetus jumps, we can confirm that this is in fact a thickened nuchal translucency, and we can measure it when the fetus is separate from the amnion. You can see it's thickened at 3.3 millimeters. So overall, the measurement of the nuchal translucency when it's abnormal is a fairly good predictor. It's fairly sensitive for aneuploidy. If it's thickened between 11 and 14 weeks to above 2.2 at 11 weeks or 2.8 at 14 weeks, the positive predictive value for aneuploidy is 40 to 50%, with a sensitivity of about 70 to 85 depending on the study. So in cases like this, we might recommend chorionic villus sampling or amniocentesis. However, we have an even better test, and that is to measure the nuchal translucency, and in combination with a maternal age and a blood test, we can calculate the likelihood of aneuploidy, at least for trisomies 21 and 18, with a sensitivity of 25% and a false positive of 5%. So now we are picking up more than 90% of these fetuses. So we have a much improved test if the nuchal translucency is used in combination with the blood test. So here's a fetus at 13 weeks gestation. We looked at the fetus. We saw marked thickening of the nuchal translucency to over 7 millimeters. Absence of the nasal bone helped us suggest this was trisomy 21. Here you can see there's a cystic hygroma associated with this thickened nuchal translucency. And in our view of the fetal heart, we see an echogenic focus inside the left ventricle, another clue that this was likely trisomy 21. Note the skin thickening all around the trunk of this fetus. The cystic hygroma extended all the way down. Now this fetus came at 11 weeks gestation, had a thickened nuchal translucency of 4 millimeters, but when she came back for her CVS, or chorionic villus sampling, at 12.6 weeks, it was only 2.1 millimeters, which is normal. Well, it's been shown that the risk of aneuploidy and anomalies is related to the thickest nuchal translucency. So her risk should be calculated based on the 4 millimeters at 11 weeks. And in fact, the nuchal translucency tends to peak at about 11 weeks, but the blood test works better at about 12 or 13 weeks, and that's why the range that this test is done is from 11 to 14 weeks to try to capture the overlap to improve the sensitivity. If the nuchal translucency is abnormally thickened and the chromosomes prove to be normal, there is still an increased rate of cardiac anomalies as well as other anomalies, and so at this point a careful fetal survey should be performed at 18 weeks gestation. In fact, the greater the thickness of the nuchal translucency, the higher the risk there is that the fetus has a cardiac anomaly. You can see that when the nuchal translucency was thickened but still measured less than 3.5 millimeters, the risk was 18 per 1,000 fetuses. But when it was more than 5.5 millimeters, 5.5 or more, the risk was almost 10 times that much. So it does go up as the nuchal translucency thickened. So here's a fetus at 11 weeks gestation. The nuchal translucency measured 4.4 millimeters, quite thick, very concerning. Chromosomes proved to be normal, but on follow-up scan during her 18-week scan, we found a cardiac anomaly. Tetralogy of Fallot was diagnosed with narrowing of the pulmonary artery and widening of the aorta. With the ventricular septal defect, this overriding aorta helps us make the diagnosis. Now, cystic hygroma is related to thickening of the nuchal translucency. This is a lymphatic abnormality that is even greater than involving just the neck. It leads to edema and fluid-filled spaces, often most prominent in the posterior neck. This is also the most common location where they may persist into the second trimester. This is also associated with the same kinds of abnormal chromosomes as seen with thickening of the nuchal translucency, Turner syndrome, trisomies 21, 18, and 13. It can also be seen with Noonan syndrome, but this situation has normal chromosomes. We did a study of almost 1,000 fetuses to look at the cystic hygroma, and in our study we found that over half the fetuses proved to have abnormal chromosomes. 15% resulted in pregnancy loss of those that were not terminated, and almost 30% had anomalies even when they had normal chromosomes. So you can see the anomaly rate is quite high and the aneuploidy rate is quite high. And the types of anomalies are cardiac, as I already mentioned, that go along with also thickened nuchal translucency, but other systems as well, genitourinary, central nervous system. And as with the nuchal translucency, the thicker the cystic hygroma at the neck, the greater the likelihood of abnormality and of fetal demise in utero. Here's an example of a fetus with Turner syndrome seen at 12 weeks gestation. You can see this massive cystic hygroma surrounding the head. It has thickening at the nuchal translucency level as well as septations running through it. This is a 3D just showing the contour of this fetus with this huge cystic hygroma. Here's another one. This is in a monochorionic gestation. Here we see that one of the two monochorionic twins has a thickened nuchal translucency to 5 millimeters and a cystic hygroma with those typical septations that run through it. This can be a sign of twin-twin transfusion syndrome that has already started in the first trimester. So with monochorionic twins, this is typically a serious finding. Here's a fetus with trisomy 18. Notice the thickness behind the neck is 8.3 millimeters. Notice that there's a halo around the fetus representing the cystic hygroma. It extends around the top of the head, across the face, and down the trunk posteriorly and anteriorly. That can be typical of these diffuse cystic hygromas. Besides looking at the head and the neck, we also have the opportunity to see the trunk, to look at the thorax, to look at the abdomen, and even to look at the extremities. We may make diagnosis of early hydrops in some fetuses by seeing fluid inside the chest, a pleural effusion, and when we do, it's often accompanied by a cystic hygroma. So here's a fetus at 9 weeks gestation. You can see on the scan that there's fluid around the heart here. On a transverse view of the chest, you can see the heart with big pleural effusions. This is actually the inversion mode of the fetus, showing how much fluid there is in a chest, cast on the 3D, just outlining the fluid in the fetus. This is a different fetus, 12 weeks gestation. You see thickening of the nuchal translucency. We see a cystic hygroma all around the chest. We see at the level of the thorax pleural effusions posteriorly in both sides of the chest. She came back 2 weeks later. Now we can see that we still have that cystic hygroma extending all the way down the trunk into the abdomen. We still have bilateral pleural effusions. Of course, they're easier to see at 14 weeks because as the fetus grows, these findings are easier to identify. We also can see the heart, particularly if we do a transvaginal scan. Here's a beautiful 4-chamber view of a 12-week fetus done with a transvaginal scan. The 2D and the clip both show an intact septum, nice normal shaped ventricles and atria, normal size, symmetric. But here's an abnormal fetus. You can see the heart is clearly abnormal. This has likely an AV canal with communication between the atria and the ventricle. Also, I hope you notice this pericardial effusion around the heart, as well as echogenic bowel. This fetus proved to have trisomy 21. And here's another fetus with a thickened nuchal translucency of 4.3 millimeters, seen in the first trimester at 13 weeks. This fetus also has a pericardial effusion. So these findings alert us to the fact that this fetus may have aneuploidy or may have a cardiac defect, which I think there may be already. We can see a ventricular septal defect. We may not make the cardiac diagnosis at this age, but it does, in some cases, we can say there's clearly a cardiac anomaly. And this fetus had normal chromosomes, but came back at 18 weeks to look at the heart more closely and had a demise. I don't think any of us would miss this, but do look at the trunk of those first trimester fetuses because sometimes the heart is outside the chest. This is a fetus with Ectopia cordis. Heart has been extruded through a defect in the anterior thorax. Here it is pumping outside the chest in color and in grayscale. Now we can also see structures in the fetal abdomen. The stomach and the bladder are almost always identifiable before the end of the first trimester. We may see the kidneys, and we also can evaluate the ventral wall to look at the cord insertion as well as to identify how many umbilical arteries there are in the umbilical cord. So here are transabdominal and transvaginal scans of 13-week fetuses showing that we can see the stomach in the left upper quadrant, we can see the bladder in the pelvis, and we should be able even to see the kidneys in some cases. This was a transvaginal scan only. You can see how well we can make out the kidneys in these fetuses, provided they're in a good position for the transvaginal scan. They're not always in perfect position. And here we see the ventral wall at 13 weeks gestation, with the only thing traversing the ventral wall at this stage being the umbilical cord. Now that we're looking at the fetus so carefully at this gestational age, we have to remember some of the developmental findings in the fetus that should not be misinterpreted as abnormal. And one of these is physiologic bowel herniation. Between 8 and 12 weeks gestation, the fetal bowel is partially extruded into the base of the umbilical cord. It's part of the development of the bowel as it develops to position itself properly inside the abdomen. So to see a bump at the base of the umbilical cord is a normal finding, provided the herniated midgut measures less than 7 millimeters and provided it goes back inside by 12 weeks gestation. So here is a 10-week gestation with physiologic bowel herniation. On a sagittal view of the fetus, we see a nice bumpy contour to the anterior abdominal wall at the cord insertion. On the 3D images, you can see that this expansion of the base of the cord is related to the umbilical cord, just like an omphalocele would be, except that this is physiologic bowel herniation, a normal finding. Here's another one at 10 weeks gestation. We see a little bowel next to the umbilical cord here and here. Here it is on the 3D ultrasound showing that protrusion next to the cord. So this is usually a normal finding. Occasionally it's not, though. Here at almost 12 weeks gestation, we now see a bulge at the umbilical cord with the umbilical cord that is much bigger than the 7 millimeters that's accepted. This is a very large omphalocele. We see it here on transverse view. We see it here with the cord traveling through this omphalocele. And here we can see this fetus has a ball in front of it. This is an omphalocele. On the 3D image, it looks like a basketball in front of the fetus. So we can also identify omphaloceles some of the time. If we see that bump that persists past 12 weeks gestation, that's also abnormal. Here we see a little bit of bowel protruding into the base of the cord here. Here we see it traveling with the vessels. So this is a 13-week when we should no longer see that bowel there. Just to be certain, of course, we will get a follow-up, and by 20 weeks gestation, we saw extruded bowel into the base of the cord, a small omphalocele in this fetus. We also may pick up a gastroschisis. Here's a 14-week gestation where there's a lobular mass protruding from the anterior abdominal wall. In this case, we could see that the mass was adjacent to the cord insertion, not part of it, and this was an early gastroschisis. We do see the bladder during the first trimester. We do want to identify those cases where the bladder is abnormally dilated. This can be an early sign of posterior urethral valves. Now remember that the amniotic fluid around the fetus in the first trimester is only filled in part by the fetus. So a lot of it is there already physiologically as part of the pregnancy, and therefore we may see a dilated bladder and normal amniotic fluid, and yet the fetus may have posterior urethral valves. So just looking at the bladder should raise our concern. Here's an example. This is a 12-week gestation. This fetus has a very dilated bladder on sagittal and transverse view, but the amniotic fluid at this stage was still close to normal. Here's another one at 12 weeks gestation. We see a somewhat dilated bladder. We were a little bit concerned about this fetus, but we're not. We just suggested that it's probably abnormal and do bring that fetus back. Here she is at 18 weeks when she came back, and we see a hugely dilated bladder with that typical keyhole defect at the posterior urethra, that dilated posterior urethra. Both kidneys now have marked hydronephrosis, and unfortunately these kidneys already have echogenic cortices because of the dysplasia that has occurred due to this obstruction. Also look at the extremities of the fetus, at least to see if they're present. With our 3D imaging, we can see that they're present all the way down to the hands and the feet. This is a 13-week gestation. We can see the arms and the legs, the hands, the legs, the feet. So we know that they are present at this gestational age. Occasionally, you'll pick up some abnormalities. This fetus has polydactyly. I was scanning this fetus, and I thought there was one too many, and I was a little bit concerned, but at this age, I'm not sure I would call it. But the astute father sitting in the chair watching the screen said, "Oh, does that fetus have an extra finger?" Well, what am I supposed to say? So I said, "Well, I think maybe it might." And he said, "Oh, I was born with extra digits." So when it's, when it's inherited, the prognosis is much better. Sure enough, when she came back at 19 weeks gestation, we see that there's postaxial polydactyly with that extra digit next to the little finger. This fetus has very abnormal posturing of the hands. This is a finding that you'll see with things such as trisomy 18 or with arthrogryposis. So when this is seen, we should raise concern for these kinds of anomalies so that these patients are followed up sooner and given counseling earlier rather than later. And this fetus has extremely short upper and lower extremities, also a very narrow trunk, but the cranium was normal in size at 13 weeks gestation. Also notice that the hands are normal size despite the very short upper extremity, and this is a fetus with Thanatophoric Dysplasia. If we identify this at 13 weeks gestation, then chorionic villus sampling can be performed and the appropriate genetic testings can be done prior to had we found this in the second trimester. We also may pick up amniotic band syndrome in the first trimester. This is an abnormality that results from early rupture of the amnion. It is not really a syndrome because it is a chance event. If it occurs in a pregnancy for a couple, the likelihood that it will occur in a subsequent pregnancy is not increased compared to anybody else's chance. With early rupture of the amnion, fibrous bands can entrap and adhere to the fetus because the amnion does provide protection from that. And so when it ruptures, these fibrous bands crisscross the gestational sac. When they adhere to or entrap a portion of the fetus may have limb amputations or serious deformities that may involve the head, the trunk, the extremities, may have encephaloceles, ventral wall defects, may have ectopia cordis or absence of a limb. So here's a fetus at 11 weeks gestation. The fetus is markedly distorted. You can see that the head is disrupted with protrusion of material superiorly. The trunk is disrupted with protrusion anteriorly. But also notice how these bands crisscross the gestational sac. These bands are not just the loose amnion. These are fibrous bands that develop across the chorionic space. And so it's not just that one membrane can attach to the fetus, it's all of these can and entangle the fetus to lead to very severe, very devastating abnormalities. Here's another one. We could see this because of the shape of the trunk was very abnormal, but also you can see the band extending from the edge of the gestational sac, entrapping this portion of the fetus that has been disrupted, part of the anterior abdominal wall. It's interesting to note that there's a thickened nuchal translucency here. Sometimes you'll see associated markers or pointing to the fact that this fetus has had these deformities develop. I'll spend the last few minutes talking about the umbilical cord and the cord insertion. We actually can see the umbilical cord and can see how many vessels are in the cord before the end of the first trimester to identify two vessel cords and alert us as to what we should do there, and also to see actually cysts along the cord. When we see a single umbilical artery, the only way really to do this in the first trimester is to use color Doppler looking at the fetal bladder to see how many vessels travel from the iliac arteries to the umbilical cord. And here's what you'll see with the two-vessel cord. Instead of seeing two vessels, one on either side of the bladder, you'll see a single vessel traveling to the umbilical cord insertion. So when we identify this at 13 weeks gestation, we can tell the patient that the fetus has a two-vessel cord. This can be associated with other anomalies, and so we need to have a good fetal survey early in the second trimester to look for those abnormalities. About 30% of fetuses with two-vessel cords do have anomalies detectable at ultrasound. The other 70% don't, but they are at slightly increased risk for intrauterine growth restriction. Sometimes we'll see a cyst at the base of the cord. These are seen anywhere from 0.4 to 3.4% of pregnancies. We usually see them at about 8 to 9 weeks gestation, and they typically resolve before the second trimester. And when they resolve before the second trimester, the outcome is typically normal. However, if they do persist, then the risk of aneuploidy and anomalies does increase, particularly anomalies such as Omphalocele, patent urachus, urinary anomalies. So when we see them at 8 to 9 weeks gestation, we're obligated to tell the patient that these often go away, it's nothing to worry about, but we'll watch it, and if it does persist, we'll look closely for the associated anomalies and assess for aneuploidy. Here's a 9-week fetus, nice umbilical cord cyst right here. This one resolved by 12 weeks gestation. But here's a little teeny one at 13 weeks gestation that we can see here and here. The fetus at this point appeared otherwise normal, but by 20 weeks gestation now, this fetus had an omphalocele. So this was our tip-off to look carefully at this fetus. You can see on the sagittal view, bowel herniated into the base of the cord. You can see it here on the clip, as well as on the 3D image where this fetus is looking down to admire its omphalocele. So I hope you'll remember the fetus when you do your first trimester scanning. It's more than just measuring the crown rump. Do look at the fetus and make sure it's developing normally.